Video 5-34 shows how the thoracic limb is protracted with medial rotation of the elbow and the lateral position of the paw. Use slow motion to fully appreciate this movement in your patient. The elbow appears mildly deviated medially when the limb is supporting weight, but this is exacerbated as soon as the limb is lifted off the floor for protraction. When the examiner stands over this dog to assess the degree of rotation of the shoulders by rotating the brachium medially and laterally, note the decreased range of motion when the left brachium is rotated medially. This is caused by restriction from shortening of the lateral rotator muscles of the shoulder, infraspinatus and teres minor. Normally, the potentially very mobile shoulder joint is kept in its straight craniocaudal course during protraction by the balance between the medial rotators, subscapularis and teres major muscles, and the lateral rotators, infraspinatus and teres minor muscles. This dog has experienced shortening of the left infraspinatus muscle, which was most likely injured while hunting. If she stepped into a hole while running and overextended her left shoulder, the distal edge of the spine of the scapula would be suddenly forced into the distal portion of the infraspinatus muscle, causing it to tear. As this injury healed and fibrosis occurred in the muscle, it could shorten and create a mechanical tension that would force lateral rotation and limit medial rotation. Note that when you force excessive lateral rotation at the shoulder, the elbow rotates medially. This is not a problem at the elbow. The abnormal position of the elbow reflects the primary Schauder disorder. Figure 5-40. Treatment requires removing the fibrous portion of the affected infraspinatus muscle. The last portion of the video of Cephas shows normal gait after this surgery. The next three videos show two dogs with the same infraspinatus contraction and histories similar to that of the dog in this case example. Video 5-35 shows a 4-year-old pointer crossbreed. Videos 5-36, A and B, show an 8-year-old male Labrador retriever viewed in normal and slow motion. This disorder is presented here because it is often confused with a nerve disorder, but that cannot explain what is happening here. Experimental sectioning of the suprascapular nerve will denervate the supraspinatus and infraspinatus muscles, but this will not cause any gait abnormality in the dog or the cat, only atrophy of these muscles. Horses that run into a doorway or fence post with a cranial aspect of the scapula may injure this nerve where it crosses the scapular notch on the cranial surface of the neck of the scapula. This may cause a slight lateral deviation, abduction, or lateral buckling of the shoulder when weight is borne on that limb. The collar used with the draft horse may chronically compress this nerve at this site if the collar is too tight. Usually, the denervation atrophy of these muscles is the most obvious clinical sign. The lateral deviation of the shoulder during walking is very mild. The disorder is often referred to as Sweeney, which was the name of a type of collar made for working draft horses. This equine occupational hazard is similar to carpal tunnel syndrome recognized in humans. Lesions that involve the other thoracic limb nerves do not produce any significant clinical signs. Experimental sectioning of both the median and ulnar nerves causes only a slight carpal overextension drop of the carpus. More important, when you observe a significant carpal overextension that produces a pomegranate posture, it is a reflection of loss of the integrity of the palmar carpal ligaments. If you remove all the nerves and muscles from a thoracic limb specimen, you cannot manually force the carpus into a pomegranate position as long as the palmar carpal ligaments are intact. These ligaments become stretched when the thoracic limb has to bear more weight than usual, as when a young dog has a fracture in one thoracic limb and bears all its weight on the normal limb for a period of weeks. That normal limb will slowly assume a more pomegranate posture. Older dogs that are overweight often assume this carpal posture. Chronic neuromyopathies cause dogs that have lost the normal muscle strength necessary to support weight to assume a pomegranate posture. This clinical sign reflects the secondary loss of integrity of the palmar carpal ligaments and is not a sign of a specific neuromuscular disorder. A plantigrade posture in a pelvic limb has a very different pathogenesis. It will be described in case examples 5-17 and 5-21 in this chapter in the sections on pelvic limb disorders. LMN. LMN paraplegia, dog signalment, 5-year-old male Great Dane, Figliaro chief complaint, unable to walk with the pelvic limbs history. 2 days before our examination of this dog, he was outdoors walking on a leash with his owner. Upon returning home, he stumbled going up the stairs and collapsed in the house. The next morning he was seen by a veterinarian who diagnosed paraplegia and then made arrangements to get specialty studies for this dog. Examination. Video 5-37 shows that this dog could get up only on his thoracic limbs. When supported by his tail, he walked well with the thoracic limbs, but the pelvic limbs were dragging on the ground, and only an occasional slight hip flexion occurred in an attempt to advance the limbs. The pelvic limbs were hypotonic, with normal patellar reflexes but no flexor reflexes when digits 3 through 5 were stimulated. Noxious stimulation of the medial side of the limb or the cranial aspect of the thigh elicited a slight flexion of the hip. This dog was very stoic and displayed only minimal displeasure in response to this method of stimulation. The tail and anus were atonic, areflexic, and analgesic. Analgesia of the perineum, the caudal thigh, and all of the cross and paw, except for the medial surface, was seen. A line of analgesia existed at about the L7 spinous process. This could be reliably determined only by using an electric cattle prod. The bladder was enlarged, and urine was constantly dribbling from the penis. No discomfort was elicited when the lumbar and sacral vertebrae were palpated. Anatomic diagnosis: L6, L7, all the sacral and caudal spinal cord segments, the spinal nerve roots, the spinal nerves, possibly some mild involvement of a few more cranial lumbar segments. The basis for this anatomic diagnosis is as follows. The examination showed complete lack of LMN and saw function to the tail, caudal nerves, anus, perineum, pudendal nerve branches from the sacral plexus, caudal thigh, caudal cutaneous femoral nerve from the sacral plexus, caudal thigh muscles and all the crural muscles and the skin of the cross and paw except for the medial surface, sciatic nerve, L6, L7, S1. Function was normal in the distribution of the femoral nerve, L4, L5, to the quadriceps femoris, normal patellar reflex, and the medial side of the distal thigh, crus, and paw, saphenous branch of the femoral nerve, in the distribution of the lateral cutaneous femoral nerve, L3, L4, to the cranial and craniolateral side of the proximal thigh, and in the distribution of the genitofemoral nerve, L3, L4, to the skin of the proximal medial thigh. When these intact nerves were stimulated, the dog's response was a mild flexion of the hip using the iliopsoas muscle, which is innervated by almost all of the ventral branches of the lumbar spinal nerves. The line of analgesia along the dorsal lumbar area was usually about 2 vertebrae caudal to the cranial aspect of the lesion because the dorsal branches of the lumbar spinal nerves that are stimulated course quadrantally from their intervertebral foramen for the distance of about 2 vertebrae. The response to the electric prod at about the L7 level occurred because of impulses passing through the intact dorsal branches of the L5 spinal nerves. The lack of much hip flexion when the dog was supported to walk suggested that perhaps the white matter cranial to the L6 level was more involved. The analgesia of the skin of the penis, dorsal nerve of the penis, a branch of the pudendal nerve from the sacral plexus, and the normal nociception in the skin of the prepuce, genitofemoral nerve from the ventral branches of the L3, L4 spinal nerves, are not shown on the video. Differential diagnosis: external injury, fibrocartilaginous embolic myelopathy, FCEM, intervertebral disc extrusion, neoplasia, myelitis, and lumbosacral syndrome when history supports a peracute onset and no obvious progress. Sign of clinical signs after 24 hours. 2 major disorders should be considered over all other differential diagnoses. 1. External or internal trauma and 2. Vascular compromise. When clinical signs involve the spinal cord or cauda equina, the possibility of an acute intervertebral disc extrusion must be included. It would be considered a form of internal trauma. The history of Figliaro in this case example does not include any external trauma. This dog is a breed in which intervertebral disc extrusions usually do not occur until they reach middle age or older. Therefore, if the dog is 5 years of age, this diagnosis must be considered. The absence of any indication of discomfort when the lumbosacral vertebrae were palpated would be more likely with a vascular compromise than with an intervertebral disc extrusion, but many exceptions to this clinical observation exist. The most common vascular compromise is a sudden hemorrhagic or ischemic infarction of the spinal cord secondary to a shower of fibrocartilaginous emboli that blocks the arterial supply. Such a peracute onset would be unusual for a neoplasm, especially one that was intraparenchymal, within the spinal cord parenchyma. However, extraparenchymal neoplasms, either intradural or extradural, that grow and compress the spinal cord slowly may suddenly produce clinical signs when the autoregulatory system that maintains the vascular perfusion of the spinal cord fails or a hemorrhage occurs in the neoplasm. Myelitis in these spinal cord segments would produce a progressive clinical disorder. The same chronic clinical course would be expected for a lumbosacral syndrome, and it would not produce the severe degree of neurologic deficit that has occurred in this dog. Fibrocartilaginous embolic myelopathy radiography was normal in this dog, and cisternal myelogram showed a mild intraparenchymal swelling at the level of the lumbosacral intumescence. This study supported the diagnosis of FCEM, which could cause this swelling from hemorrhage and edema. Treatment for this disorder is mostly supportive. The use of corticosteroids has not been shown to be of any significant value in spinal cord injury and may have serious side effects. When FCEM causes such severe gray matter damage as has occurred in this case, the prognosis for spontaneous recovery is poor. However, when it occurs at other levels of the spinal cord, and when the signs are caused by dysfunction of white matter and are less severe, spontaneous recovery is common. Our rule of thumb is that if no improvement at all is seen in 14 days, it is unlikely that any recovery will occur. However, I have seen improvement in FCEM patients after as long as 16 weeks after the initial onset of signs. Therefore, patience is recommended in the care of these animals. This dog was euthanized after 2 weeks of supportive care, and autopsy showed an extensive hemorrhagic and ischemic infarction of most of the components of the spinal cord, from the L6 segment caudally, figures 5-41 through 5-43. These lesions were associated with numerous emboli of fibrocartilage arteries and a few veins on the surface of the spinal cord as well as in the parenchyma. This disease is described in detail in Chapter 10, along with diseases of the spinal cord in small animals, sacrocaudal dysfunction, horse signalment, 8-year-old male warm blood horse chief complaint, abnormal facial expression and rectal impaction history. About 10 days prior to examination, the owner noticed that the right ear of this horse drooped and the nose was deviated to the left side. For 1 week, no movement of the tail was observed. Feces occluded the anus and rectum and had to be removed manually, and the penis often protruded from its sheath. Examination. Video 5-38 shows that a slow, plodding gait and circling were normal for this horse. Note the prominent palpable buccal branches of the right facial nerve. The skin of the penis, which is innervated by branches of the dorsal nerve of the penis from the sacral plexus, was analgesic. However, the skin of the prepuce, which is innervated by branches of the genitofemoral nerve from the ventral branches of spinal nerves L3 and L4, had normal nociception. Note the atonia, areflexia, and analgesia of the tail, anus, and perineum. The area of cutaneous analgesia was in the autonomous zones of the caudal and caudal sacral spinal nerves. Anatomic diagnosis: right facial nerve, bilateral sacral 3 to 5 and caudal spinal cord segments, spinal nerve roots and spinal nerves. Differential diagnosis: polyneuritis equi, neuritis of the cauda equina, equine protozoomyelitis, discospondylitis abscess, cryptococcal leptomanitis and radiculitis, neoplasm. Polyneuritis equi, or neuritis of the cauda equina. Polyneuritis equi, which is also known as neuritis of the cauda equina because of the location of the major lesions, is the most presumptive diagnosis in this horse. The cause of this disease is unknown, but an autoimmune disorder is strongly suspected. The intradural spinal nerve root lymphoplasmacytic inflammatory lesions are very similar to those seen in polyradiculoneuritis in dogs, but in the horse, an additional extradural granulomatous lesion enlarges and causes the extradural portion of the spinal nerves to adhere, forming a mass lesion within the vertebral canal. Figures 5-44 through 5-46. The reason for the formation of this extradural lesion is unknown. Lumbar CSF often has an elevated protein content and a pleocytosis with non-suppurative leukocytes. The prognosis for recovery is poor. Continual care is necessary to ensure elimination of feces and urine. Occasionally, a mild pelvic limb gait deficit is present if the lesions become extensive enough in the caudal, lumbar, and cranial sacral spinal nerve roots. This will appear as a partial sciatic nerve dysfunction. Histologic evidence of lesions may be present in many of the spinal nerve roots, but only occasionally are clinical signs seen in the limbs. However, involvement of cranial nerves 7, 8, and, less often, 5 is seen in some horses. It relates to the facial paralysis in this horse. It is unusual for the cranial nerve deficits to occur before those that involve the sacrocaudal nerve roots, as happened in this horse. Equine protozoomyelitis limited to the spinal cord segments is the most likely other cause of these clinical signs. To affect the facial nucleus and the brainstem and no other system located there is possible with this protozoal agent, but it is unusual. If no serum antibodies to S-neuron are present, this diagnosis may be considered unlikely. Discospondylitis at the L6, S1 articulation or an abscess at this site would be much more likely in a foal than in a horse of this age. Neoplasms of the spinal cord, nerve roots, and extradural space are rare in horses. Be aware of melanomas in white or gray-colored horses. I have seen one case of cryptococcal leptomanitis and radiculitis that involved this anatomic site in an adult horse with identical sacrocaudal clinical signs. This fungal agent should be observed in the lumbar CSF. Sacrocaudal dysfunction, dog signalment, 10-year-old male German Shepherd dog, Max chief complaint, urinary and fecal incontinence and discomfort when standing up. History: for the past few weeks, when he stands up after a nap, a puddle of urine or occasionally a small clump of feces has been left on the floor, and his tail has often been soiled with feces. Max gets up slowly, occasionally cries out, and resents any touching of the pelvic region. Examination: Max had a normal gait except for a slight overflexion of each tarsus. He had no patellar reflex in the left pelvic limb, and the reflex was depressed in the right pelvic limb. The flexor reflexes and postural reactions were normal. Tail and anal tone were poor. The perineal reflex seemed depressed. Max strongly resented firm palpation at the level of the lumbosacral articulation, especially if it was done while the pelvic limbs were raised off the floor. Anatomic diagnosis: L7, sacral and caudal spinal cord segments, spinal nerve roots, or spinal nerves. This anatomic diagnosis explains the paretic tail, the incontinence, and the overflexed tarsus. Be aware that a mild overflexion of the tarsus is normal in this breed and often difficult to differentiate from the posture of a mild tibial nerve deficit. The neuronal cell bodies of the tibial nerve portion of the sciatic nerve are located in the L7 and S1 spinal cord segments. A lesion at the L4, L5 spinal cord segments, their roots or spinal nerves, or the femoral nerves would be needed to explain the abnormal patellar reflexes. However, this abnormality may have nothing to do with the chief complaint or the other clinical signs in this dog, as a small percentage of old dogs lose one or both of their patellar reflexes with no other indication of any femoral nerve dysfunction. It is age-related and probably represents some disturbance to the sensory portion of the reflex arc because no evidence of any inability to support weight or any atrophy of the quadriceps muscle exists. 91. Two anatomic features that relate to this anatomic diagnosis are important. The involvement of the caudal nerves leading to the tail strongly supports the hypothesis that the lesion is within the vertebral canal because these nerves only course through this canal and then leave it through the intervertebral foramina to innervate the axial muscles of the tail directly. They never have any course through the pelvic cavity. If you destroyed all the neural components that are located in the vertebral canal at the lumbosacral articulation in the adult dog, it would include all the caudal and sacral nerves and possibly the L7 spinal nerves. Note how such a partial destruction agrees with the anatomic diagnosis in this case. Note also that the only gait abnormality that a lesion at this site can explain is a partial sciatic tibial nerve deficit. Some dogs that have severe discomfort localized to this articulation have an entrapment of one or both of the L7 spinal nerves caused by the degenerative joint disease at this articulation. In this dog, Max, the normal postural reactions and flexor reflexes suggest that the involvement of L7 and S1 in the lesion was minimal. Differential diagnosis: lumbosacral caudoequina syndrome, intervertebral disc protrusion, discus spondylitis, neoplasm, external injury. Note: some authors include all of the disorders listed here except for external injury as part of the lumbosacral syndrome. We have joined the majority and limited the use of the term syndrome to those disorders that are a form of degenerative joint disease. DJD, lumbosacral syndrome, or caudoequina syndrome. Lumbosacral syndrome, or caudoequina syndrome, is the most presumptive clinical diagnosis for Max. These are the two terms most commonly used for the DJD that occurs at the L7, S1 articulation in older dogs, especially the larger breeds. Do not confuse this caudoequina syndrome with the equine disease described earlier. That one is a neuritis of the caudoequina. No precise anatomic definition of the caudoequina exists, and the term is applied to the collection of nerves that courses along the surface of the conus medullaris. Most authors include the caudal, sacral, and L7 spinal nerves in this term. Other names for this degenerative joint disease include degenerative lumbosacral stenosis, lumbosacral malformation malarticulation, lumbosacral instability or spondylolisthesis, and lumbosacral spondylopathy. The term lumbosacral stenosis fits the compression here but has been more commonly used for a malformative vertebral disorder at this articulation that occurs in young adults of small breeds. It is preferable to refer to this as congenital lumbosacral stenosis in these young small breed dogs. Lumbosacral syndrome represents a plethora of lesions that are classified as chronic DJD. It may involve the dog's fibrous articulation, with proliferation of the annulus fibrosus of the intervertebral disc dorsally into the vertebral canal, spondylosis with excessive bony proliferation on the quadventral and lateral aspects of the body of L7 and on the cranioventral and lateral aspects of the body of S1, often with fusion, is common at this articulation and may be found in many dogs with no clinical signs of any nerve compression. DJD of the articular processes results in a marked thickening of the processes in the joint capsules. Proliferation of the associated yellow and dorsal longitudinal ligaments may contribute to the narrowing of the vertebral canal at this site. The cause of the DJD at this articulation is unknown but may reflect a chronic malarticulation with or without some instability. Prior to MRI and CT, many radiographic contrast procedures were used to confirm this lesion, but these attempts were hampered by the termination of the subarachnoid space cranial to this articulation in many of the large breed dogs, or else the space was as narrow as a thread at this site. Fat in the epidural space sometimes interfered with epidurography. The use of intraosseous vertebral venography to show compromise of the internal ventral vertebral venous plexus at this articulation was only sporadically reliable. Most neurologists now prefer MRI. Decompressive surgery, with or without stabilization, is the treatment of choice but has variable results. Early detection of the disorder, prior to permanent fecal or urinary incontinence, is paramount for successful surgery. Intervertebral disc protrusion. Intervertebral disc protrusions may occur at any of the intervertebral fibrous articulations. They are more completely described along with spinal cord disease in Chapter 10. Such a protrusion could occur at the L7, S1 articulation without other evidence of any DJD and cause the clinical signs observed in this dog. Diagnosis and treatment are the same as for the lumbosacral syndrome. Discus spondylitis. Discus spondylitis resulting from bacterial or fungal causes is common at this site but may occur at any fibrous intervertebral articulation. This lesion is often associated with severe discomfort and sometimes causes the systemic effects of an infection, with fever and leukocytosis. In some dogs, the same infectious agent may cause cystitis. This diagnosis may often be made with plain radiography, but remember that the radiographic changes take a few weeks to become evident, and you should not rule out this diagnosis just because no radiographic changes are evident. MRI and CT may be useful in subtle cases. We have seen discus spondylitis secondary to previous vertebral surgery at the lumbosacral articulation. The ideal antibiotic treatment is based on culture of the blood or lesion aspirate with identification of the organism and antibiotic sensitivity testing. Appropriate antibiotic therapy may also be inferred from culture and sensitivity testing of urine. Occasionally, surgical decompression is necessary in these cases if medical management with antibiotic therapy is unsuccessful or if compression is severe. Neoplasm. All of the clinical signs exhibited by Max in case example 5-10 could relate to a neoplasm that is growing at this site. The tumor could be extradural, such as lymphoma or sarcoma, or a metastatic vertebral tumor, such as hemangiosarcoma. A malignant nerve sheath tumor could occur here but not a glioma because no spinal cord exists at this level. Diagnosis requires imaging first and then histologic examination of a specimen obtained surgically or by aspiration. Treatment is dependent on this diagnosis. L7 fracture. External injury is included here because L7 fractures are fairly common after an animal has been injured in a motor vehicle accident, and if the nervous tissue damage is limited to this site. The clinical signs are similar to those seen in this case. However, the onset of clinical signs will, of course, be sudden and the signs will not progress after the first 24 to 36 hours. As a rule, traumatic lesions here usually cause more severe clinical signs. Complete LMN paralysis and analgesia of the tail and anus, analgesia of the perineum, continual urinary incontinence resulting from overflow and lack of urethral muscle function, and more significant signs of sciatic nerve dysfunction. Video 5-39 shows a 2-year-old male miniature 10 days after a fracture of L7, with ventral displacement of the caudal portion of the L7 body that compromised the vertebral canal by more than 50%. Figure 5-47. Note the ability of this dog to support weight, normal femoral nerves, and the ability to flex the hips to advance the limbs, normal lumbar spinal nerve ventral branch innervation of the psoas major muscle, but note also the loss of stifle flexion, tarsal flexion or extension, and digital extension, abnormal sciatic nerve function bilaterally. The L6, S1 spinal nerve lesions at the site of the fracture are not complete because nociception is intact on the lateral digits. Note the dilated areflexic, analgesic anus that, along with the analgesic perineum and tail, indicates complete dysfunction of the sacral and caudal nerves. This dog shows how ambulation is possible despite a bilateral sciatic nerve dysfunction. The diagnosis of the lumbosacral syndrome was made in Max, the dog in this case example, with MRI, and the dog was treated by means of a dorsal laminectomy at the L7, S1 articulation, including removal of the protruding portions of the articular processes and their joint capsule and of the protruding annulus fibrosus. Limber tail syndrome, or acute caudal myopathy. Limber tail syndrome, or acute caudal muscle injury, is a disorder of the muscles in the tail that has been described in hunting dogs, especially pointers and Labrador retrievers. 127 other terms for the syndrome include cold tail, swimmer's tail, frozen tail, and sprained tail. Until the precise pathogenesis is determined, we will refer to this disorder as acute caudal myopathy. The term caudal has replaced coccygeal for the tail vertebrae, muscles, blood vessels, and nerves. Dogs with this syndrome often present with a completely flaccid tail or a tail that is held in a dorsal plane, horizontally, for several inches from the tail base and then hangs ventrally with no tone. The clinical signs of tail paresis and discomfort most commonly develop after vigorous exercise, which includes hunting or swimming. I most commonly see Labrador retrievers with this syndrome 1 to 2 days after spending a day swimming at the beach. Other predisposing factors include prolonged cage transportation and exposure to cold, wet weather. Despite the marked degree of flaccidity in the tail, nociception is intact. Ancillary studies show a mild elevation in the level of serum CK and spontaneous electric activity on EMG that is restricted to the caudal muscles. Thermography and scintigraphy also show abnormalities restricted to these caudal muscles. Histologic study of the affected caudal muscles shows muscle fiber lesions compatible with ischemia. These lesions are similar to those seen in human muscles affected by an acute compartmental syndrome. This syndrome occurs in muscles that are enclosed by a relatively thick layer of fascia and are adjacent to bone. Stressful events that affect these muscles led to edema and subsequent ischemia caused by the non-compliant facial sheath. This disorder must be differentiated from other causes of tail trauma and lesions such as intervertebral disc protrusion extrusion, neoplasia, the lumbosacral syndrome, and radiculitis, which affect the caudal spinal cord segments or caudal spinal nerves. Most dogs with this myopathy recover spontaneously with a few days of rest. The use of non-steroidal anti-inflammatory therapy may enhance recovery, and drugs to decrease the patient's discomfort are recommended. NMD paraparesis, dog signalment, 3-month-old male English Springer Spaniel chief complaint, unable to use pelvic limbs normally history. All 4 puppies in the litter began to walk at 4 to 5 weeks of age. By 7 weeks, 3 of the 4 exhibited difficulty walking with the pelvic limbs. In 2 puppies, this progressed to paraplegia, with the pelvic limbs fixed in an extended position, and they were euthanized. The 3rd puppy, this patient, was still able to move one pelvic limb, and the clinical signs stabilized at about 10 weeks of age. Examination. Video 5-40 shows this dog at 4 months of age. Note the occasional acquired bunny hopping the dog used to get around. Note the better use of the left pelvic limb, which flexed well at the hip to advance the limb, but the tarsus was overflexed because of his lack of ability to extend it. Tibial nerve. Occasionally, he stood on the dorsum of the paw, fibular nerve. The left stifle was overextended to accommodate for the overflexed tarsus, but no patellar reflex could be elicited. Femoral nerve. This left pelvic limb was hypotonic and only flexed well at the hip when the flexor reflex was tested. Sciatic. The right pelvic limb moved only by hip flexion. Intact lumbar spinal nerve ventral branches to the psoas major muscle. The rest of the joints were nearly mobile because of the severe denervation atrophy of all the muscles and the forced overextension of the stifle and tarsus, both of which were angled in the wrong direction. These joint abnormalities are the result of denervation atrophy in a young dog whose bones are growing in length. These limb deformities, contractures, arthrogryposis, result from the disparity in the normal growth of bones in the limbs and the abnormal shortening of the associated muscles. Denervation atrophy does not do this in the adult dog. The tail, anus, and perineum were normal in this patient. The thoracic limbs were normal, as were the cranial nerves. Anatomic diagnosis: L4, S1 spinal cord segments, spinal nerve roots, spinal nerves, femoral and sciatic nerves. The muscle these nerves innervate. Differential diagnosis: protozoal radiculitis, motor neuron disease, myelitis, canine distemper, fungal, granulomatous, discus spondylitis, neoplasm, intervertebral disc extrusion protrusion. Neosporosis. Protozoal radiculitis, most commonly caused by Neospora caninum and rarely Toxoplasma gondii, is the most presumptive diagnosis in these dogs, based on their ages and the character of the clinical signs. Neosporosis may affect the nervous system at any age, but for reasons that are not known, this protozoan has a predilection for the lumbosacral spinal nerve roots of young dogs. Lesions also are present in these spinal cord segments, myelitis, and in the pelvic limb muscles, myositis, but the spinal nerve lesions are the most extensive. Figures 5-48 and 5-49. Serum antibodies for N-caninum will confirm infection of the patient. However, confirmation of this agent as the cause of the disease requires autopsy with immunocytochemical staining to demonstrate the organism in the lesions. CSF will show a protein elevation and a pleocytosis of a mixed population of leukocytes. Serum muscle enzymes will be elevated when a myositis is present. We have been able to identify the DNA of the organism through PCR testing of formalin-fixed muscle specimens in which myositis was observed, but organisms were not identified by immunohistochemistry. In adult dogs, the lesions are usually confined to the CNS, and although the lesions may occur at any level, a predilection for the cerebellum is evident. Be aware that this organism may be acquired by vertical transmission from the mother to the puppies in utero and may occur in subsequent litters. It has been recognized that if antiprotozoal treatment is started as soon as any evidence of neurologic clinical signs is seen in the puppies, progression of the disease may be prevented. However, it is important to be aware that these puppies with neurologic signs may also have infection in their cardiac muscle. Adult dogs most likely acquire the protozoal agent from the infected feces in their environment as well as by ingesting tissue cysts in the muscles of intermediate hosts. Infected dogs serve as a source of this agent to pregnant cattle, in which it is a common cause of abortion. Video 5-41 shows Phoebe, a 3-month-old female mixed breed puppy that was taken to the teaching hospital at Cornell University by the Society for the Prevention of Cruelty to Animals, SPCA, because she had been abandoned. Note the bilateral pelvic limb abnormality, which is similar to that in the right pelvic limb of this case example. These rigid limbs have severe muscle atrophy, and the stifle and tarsus cannot be moved. The presumptive diagnosis of an L4 to S1 radiculitis caused by N-caninum was supported by the presence of serum antibodies for this agent, on the basis of the assumption that the disease had run its course in Phoebe and would not progress, and with the understanding that she would never recover from these clinical signs. A veterinary student adopted this puppy and provided her with boots to prevent abrasions of the digits and a harness or a carriage for longer walks, and Phoebe has lived a high-quality life well into her teens. It should be noted that historically, prior to the discovery of N-caninum in the late 1980s and the development of immunocytochemical procedures, many cases of neosporosis were incorrectly diagnosed as toxoplasmosis based on the presence of protozoal organisms similar in appearance at autopsy. MND in the Springer Spaniel and his littermates in this case example could explain the LMN clinical signs at that age, but the asymmetry, the limitation to the pelvic limbs, and the lack of continuity progression would be unexpected. Granulomatous meningomyelitis would be unusual at this young age. Canine distemper virus and fungal agents would be unlikely to cause a focal lesion limited to the L4, S1 spinal cord segments. They usually cause multifocal disease and clinical signs that continue to progress. A neoplasm at this level or intervertebral disc extrusion protrusion would not be expected at this age. Moreover, intervertebral disc extrusion protrusion does not typically involve this many spinal cord segments unless accompanied by extensive epidural hemorrhage as a consequence of disruption of the internal ventral vertebral venous plexus. The young Springer Spaniel in this case example had serum antibodies for N-caninum but none for T. gondii and was euthanized because of the poor quality of life expected for this dog. The diagnosis of a diverticulitis, myelitis, and myositis caused by incaninem was confirmed at autopsy. Swimmer syndrome in puppies is a developmental abnormality that occurs at a critical period of growth when a normal puppy is just starting to be able to stand and walk. These are usually large puppies that lack the strength to stand. As they struggle to stand, their limbs progressively become abducted. This places excess weight on their sternums, and that causes an excessive curvature or bowing of the ribs, resulting in a flattened thorax. In an attempt to stand in this abducted position, the flailing limbs make the puppy appear as if it were swimming, hence the name of the syndrome. In time, secondary joint deformities and ankylosis may occur. Breeders who are aware of this condition have learned to prevent the problem by hobbling the puppies by loosely tying their limbs together to prevent the abduction and by providing non-skid surfaces during this critical growth period. Providing a bed of deep, soft material such as blankets may be helpful. This is not a neurologic problem or a primary muscle disorder. It is the result of a disparity in growth between the muscles and the bones and soft tissues. One or more within a litter may be affected. NMD paraplegia, cat signalment, 2-year-old castrated male domestic shorthair, Simba chief complaint, inability to use the pelvic limbs history. About 2 weeks before the examination shown on the video, this cat had been missing for 4 days, and when found, he was unable to use his pelvic limbs. Initially he was reluctant to move at all. After a few days, whenever he tried to move, the hips would flex to advance the limbs, but there was no function of the joints distal to the hips. This pelvic limb dysfunction has not changed since that time. Examination. Video 5-42 shows the characteristic gait that was described in the history. All the pelvic limb function was limited to hip flexion. Note the normal tone that was elicited when the tail and the hips were manually extended but the lack of any tone distal to the hips, especially in the tarsus, each of which is flexed. Note the atrophy of the crural muscles, the areflexia and analgesia distal to the stifle, the absent left patellar reflex, and the depressed right patellar reflex. Cutaneous nociception was absent bilaterally in all the digits in the crust but was normal on all surfaces of both thighs. In an examination of this cat, it is important to recognize that the tail, anus, perineum, and excretory functions are all normal. At the time of this examination, the temperature of the paws was normal. Femoral pulses were present but difficult to feel. Anatomic diagnosis. With regard to sciatic and femoral nerves and crural muscles, the pattern of the analgesia may be explained only by the loss of function in these nerves in their course through the limbs distal to the distal thigh level. This also explains the loss of function in the muscles distal to this level. A primary muscle disorder would not explain the analgesia observed. This unique pattern may be explained only by an ischemic neuromyopathy secondary to a compromise of the blood supply at the level of the caudal aorta or external iliac arteries. The veterinarian who first examined this cat could not feel any femoral artery pulses. The caudal crural muscles were swollen, and palpation elicited discomfort. The pelvic limb pores felt cool. Aortic thromboembolism. Once this anatomic diagnosis is apparent, no clinical disorder needs to be considered other than a thromboembolism of the caudal aorta or the external iliac arteries. The spinal cord is unaffected because the aortic lumbar spinal arteries provide adequate blood flow. The presence of an ischemic myopathy and damage to muscle cells may be confirmed by the often dramatic increase in muscle serum enzymes such as CK. Additionally, venous blood glucose measured in the affected limb is markedly lower than that measured from venous blood from an unaffected limb or from the external jugular vein. In most cats, this disorder is associated with hypertrophic cardiomyopathy, which, in itself, may be life-threatening and the source of repeat thromboembolism. No reliable treatment protocol to restore pelvic limb function has proven to be effective in these cats. Most treatments include the use of aspirin. Many cats will make partial improvement by walling off the clot and re-establishing an endothelial-lined channel through the obstruction. These clinical signs may be limited to one limb if only one external iliac artery is occluded. Euthanasia should be recommended to the owners of these cats because the thromboembolic event is very likely to recur and initially causes the patient to express pain. Simba, the cat in this case example, would not be expected to experience much more improvement in his pelvic limb gait. The owners elected to keep it and make accommodations for his abnormal ambulation. NMD paraplegia, cat signalment, adult spayed female domestic shorthair, French chief complaint, no use of the pelvic limbs history. This cat had been missing for 10 days from her home. When the owner found the cat, she had no use of her pelvic limbs and dragged herself around using her thoracic limbs. Examination. Video 5-43 shows the severe bilateral flaccid paraplegia with atonia and areflexia of the pelvic limbs, tail, and anus. These same areas were also analgesic except for an occasional mild response from the right pelvic limb digits. The abdomen was also atonic. No palpable abnormality was evident in the alignment of the lumbar vertebral spines. Anatomic diagnosis. About L1, L7, sacral and caudal spinal cord segments, spinal nerve roots, and spinal nerves differential diagnosis. External injury, fibrocartilaginous embolic myelopathy, diffuse myelomalacia secondary to an acute introvert, brow disc extrusion, abscess suppurative leptomeningitis and myelitis. Ischemic polyomyelomalacia. External injury could produce this anatomic diagnosis in 2 ways. 1. Multiple lumbar vertebral fractures and spinal cord contusion. These were not palpated, and subsequent radiographs were normal. And 2. Severe abdominal compression, as would occur if run over by an automobile, causing a thrombosis or prolonged vasospasm of the lumbar arteries and ischemic polyomyelomalacia. Alternatively, the traumatic swelling of the hip axil muscles may have compromised the blood flow in the lumbar arteries that course through these muscles to access the spinal cord. This spinal cord leads lesion may be produced experimentally in dogs, cats, and laboratory animals by ligating the aorta atrocranial to the level of the renal arteries. The severity of the lumbosacrocaudal spinal cord gray matter lesion is dependent on the duration of the vascular compromise. As a rule, about 30 minutes are required for the permanent destruction of this gray matter. I have now studied the nervous system with necropsy of 4 cats with the same history of missing for a few days and found paraplegic with these identical signs, including this patient. None of these cats had any radiographic evidence of fractures. 2 had radiographic evidence of soft tissue lesions of possible abdominal hypaxillary retroperitoneal hemorrhage. At autopsy, gross evidence of this retroperitoneal hemorrhage was seen in 3 cats, one of which had an avulsed kidney. No gross lesions were present in the vertebral canal or the spinal cord until it was preserved and sectioned, and a softening was felt in the central portion of the spinal cord segments that extended from L2 through all the spinal cord segments caudal to it. On microscopic examination, complete ischemic type necrosis of the gray matter and the adjacent white matter of the fasciculus proprius was seen. Figures 5-50 through 5-52. Gray matter is the most sensitive to hypoxia, and the white matter lesion here is in the terminal watershed zone of the branches of the ventral spinal artery via gray matter and the arteries to white matter that branch from the plexus of arteries on the external surface of the spinal cord. See figure 10-4. These lesions are identical to those described earlier following experimental occlusion of the mid-portion of the aorta. In these 4 cats, no blood vessel lesions were found, but their lumbar arteries were not examined. Our hypothesis is that all 4 of these cats were run over by cars and that their abdomens were compressed by the tires, causing varying degrees of hemorrhage and prolonged spasm of the lumbar arteries. In support of this hypothesis, E.G. examined a cat with identical clinical signs and no radiographic evidence of fractures but with the history of having been run over. The owner admitted that she had run over her cat with her car. No autopsy was allowed to prove the similarity of the lesion. Video 5-44 shows Winky, a 2-year-old spayed female domestic short hair. An ovariohysterectomy was performed at a teaching hospital. The cat was discharged a few hours after the surgery and was normal at that time, but within a few hours, she lost the ability to use her pelvic limbs. The video was made about 48 hours after the surgery. The clinical signs are identical to those in this case example. The cat was euthanized, and a ligature was found around the aorta at the level of the renal arteries. The spinal cord had the same gross and microscopic lesions as the 4 cats described earlier. Fibrocartilaginous embolic myelopathy, FCEM, occurs in cats but is much more common in dogs. The extent of the vascular compromise rarely is more than a few spinal cord segments, which may mean that the emboli arise from one degenerate intervertebral disc. The lesion is often asymmetric and often has a significant hemorrhagic component. Usually, the fibrocartilaginous emboli may be found on microscopic examination. This disorder is described more completely in Chapter 10, which discusses spinal cord diseases in small animals. An acute intervertebral disc extrusion with subsequent progressive diffuse myelomalacia could produce these clinical signs in a dog, but we have never seen the spinal cord lesion in cats. This necrotizing lesion affects all components of the spinal cord and is described in case example 5-14. Extensive development of an abscess that spread as a suppurative leptomeningitis through the subarachnoid space in the area of this anatomic diagnosis presumably could cause the clinical signs mentioned, but that would be a progressive disorder and would occur rarely. Postoperative polyomyelomalacia, horse and calf. The same ischemic polyomyelomalacia of the lumbosacrocaudal spinal cord segments occasionally occurs during surgery in young horses 9 that have general anesthesia for surgery that requires dorsal recumbency, cryptorchidism, colic, stifle arthroscopic surgery. They recover well from the anesthesia but are unable to get up on their pelvic limbs, which exhibit flaccid paralysis. The extent of the lesion, when seen microscopically, depends on the interval between the surgery and euthanasia. Figure 5-53. It is hypothesized that during the period of dorsal recumbency, the heavy bowel causes enough compression of the aorta or its lumbal branches to result in these lesions. Fortunately, this is not a common occurrence, but once is enough to make a surgeon wary and consider shifting the position of the patient periodically during the anesthesia. I have seen these same clinical signs and these same lesions in a young calf that was anesthetized and placed in dorsal recumbency for evacuation of its abomasum as a treatment for its digestive disorder. Polyomyelomalacia in pigs. A unique polyomyelomalacia occurs in pigs that ingest excessive amounts of selenium in their diets. Selenium is used as a feed additive, and occasionally an excessive amount is mistakenly added to the feed mixture. As a result, multiple pigs fed this diet are at risk for developing neurologic signs. These are usually young pigs, 1 to 5 months old, that exhibit a sudden onset of LMN tetraparesis. The toxic effect of the excessive selenium causes a bilateral symmetric degeneration of the center of the ventral gray columns, primarily in the cervical and lumbosacral intumescences and in a few brainstem GSE nuclei. Neuronal cell bodies are spewed on the borders of the lesion, which consists of an abundance of macrophages and was numerous small blood vessels coursing through it. Figures 5-54 through 5-57. Identical lesions occur when pigs are fed 6-aminonicotinamide, an antagonist to the nicotinic acid that functions as a coenzyme. 106. 107. It is suspected that this metabolic disorder is initially toxic to the astrocytes and that the neuronal degeneration follows their loss. No treatment is available for this disorder. Recognizing and removing the source of the excess selenium prevents additional cases. Similar lesions have been reported in sheep in Africa and goats in California, but no causes have been identified. Polyomyelomalacia in Ayrshire calves. Polyomyelomalacia was reported in 3 Ayrshire calves in 1 herd in the United Kingdom, and I studied a similar Ayrshire calf in Ontario, Canada. In the 1970s, 110 of these calves were all normal at birth, but at about 10 days of age, 3 calves developed a rapidly progressive LMN paresis of the pelvic limbs, and 1 calf developed it in all 4 limbs. The bilaterally symmetric ventral gray column lesions in the respective spinal cord and intumescences were identical to those described in pigs with selenium toxicity. No toxin was identified in the environment of these calves. A metabolic disorder was proposed but not identified. LMN tetraplegia. Dog signalment. 5-year-old female dachshund. Chloe chief complaint. Unable to move history. 3 days before this examination, Chloe suddenly had difficulty using her pelvic limbs. Rapidly, over a few hours, she became unable to move them at all and dragged herself around with her thoracic limbs. The local veterinarian diagnosed a thoracolumbar spinal cord lesion and suspected an intervertebral disc extrusion. On the following day, while Chloe was hospitalized, the veterinarian reported that Chloe could not get into a sternal position and had begun to lose reflexes in her pelvic limbs. By the 3rd day she was recumbent but still alert and responsive. Examination. Video 5-45 was made on the 4th day. Note the flaccid paralysis of all 4 limbs and the atonia of the entire trunk but not the neck. This was especially evident in the abdomen. Note the atonia, areflexia, and analgesia of the tail, anus, perineum, pelvic limbs, abdomen, and thorax. The analgesia extended as far cranial as the caudal borders of the scapulae. The thorax thoracic limbs were hypotonic and nearly areflexic, but nociception was still intact. When the noxious stimulus was perceived, Chloe looked anxious, moved her head and jaw slightly, and tried to bark but had no voice because of the LMN paralysis of the thorax and abdomen. Her respirations were entirely dependent on the function of her diaphragm. Note the abdominal movements that relate to this form of respiration. Anatomic diagnosis. C6 through the last caudal spinal cord segments, spinal nerve roots or spinal nerves. From C6 to T2 this lesion is severe but incomplete. From T3 caudally, no clinical evidence of any spinal cord function is seen. Differential diagnosis. Only diffuse myelomalacia can explain this diffuse anatomic diagnosis with such an extensive loss of the GSE, LMN and XR pathways as well. Diffuse myelomalacia 63 most commonly follows an acute intervertebral disc extrusion that initially causes a severe transverse spinal cord hemorrhage and necrosis. Figures 5-58 through 5-60. Most of these extrusions occur between the T10 and L3 vertebrae and initially cause spastic paraplegia. Usually, within 1 to 3 days, progressive ischemic type necrosis spreads through the spinal cord cranially and caudally from the initial lesion. However, we have seen one dog develop this progressive myelomalacia 12 to 14 days after the initial onset of the acute paraplegia. Varying degrees of hemorrhage are associated with this necrosis. The lesion appears to reflect primarily a vascular compromise and may be the result of a sudden vasospasm of all the parenchymal arterioles. The spinal cord nerve roots in the subarachnoid space are spared, whereas all structures within the preaguile membrane degenerate. The vasospasm of the necrosis may be the result of the sudden release into the parenchyma of biologic amines such as glutamate, norepinephrine, dopamine, histamine, and serotonin. These amines are thought to be involved with the extension of the spinal cord necrosis that occurs with focal spinal cord injury but usually is limited to the adjacent spinal cord segments. This is called secondary spinal cord injury. It occurs within the first 1 to 3 days after the initial injury. Extensive research efforts are being directed toward determining ways to prevent this secondary necrosis. This diffuse myelomalacia has never followed a cervical intervertebral disc extrusion and appears to be limited to those that occur between the T10 and L3 vertebrae. A possible explanation may be based on the blood supply, which appears to be severely compromised within the affected spinal cord segments. The normal blood supply to the thoracolumbar spinal cord comes from the spinal branches of the intercostal and lumbar arteries. This is a bilaterally symmetric system that can provide a spinal artery at every intervertebral foramen. However, anatomic studies show that a marked variation exists in the numbers and sizes of these spinal arteries and even the occasional absence of a spinal branch on one or both sides. In humans, one of the spinal arteries between T10 and T12 is exceptionally large and is called the arteria radicularis magna, or the artery of Adamkowitz. It supplies many spinal cord segments both cranial and caudal to the level where the artery enters the vertebral canal. Surgeons in human medicine are very careful to avoid compromising this vessel. Studies in the dog show that a similar large spinal artery exists usually at the L5 or L6 level. Possibly, the small percentage of dogs that develop progressive myelomalacia are exceptions in which this large artery appears at a more cranial level, where the disc extrusion that is related to the development of this progressive myelomalacia occurs. Sacrifice of this large artery by compression by the extruded intervertebral disc material has the potential to compromise a large segment of the spinal cord, and the secondary effects of the spinal cord injury could extend the necrosis into the less well vascularized segments, the watershed zones, both cranially and caudally. When this progressive necrosis reaches the cervical spinal cord, death occurs as the result of respiratory paralysis. Occasionally, the spread of the necrosis stops before the thoracic limbs are affected. As soon as you recognize the clinical signs of a diffuse myelomalacia, the patient should be humanely euthanized. These dogs appear to be in considerable discomfort, which may be from the subarachnoid hemorrhage at the cranial aspect of the lesion. No ancillary procedures need to be performed to diagnose this lesion, and no treatment that we are aware of can alter the outcome. As described in Chloe in this case example, this diffuse myelomalacia most commonly follows an explosive intervertebral disc extrusion. I have seen this disorder associated with an extensive diffuse epidural hemorrhage without any intervertebral disc extrusion. In one dog with an extradural neoplasm and in 2 dogs where there was no evidence of any vertebral canal lesion at autopsy. We have not seen this associated with external trauma even when the trauma occurs in the region of the T10 to L3 vertebrae and have seen it only in dogs and not in cats. To appreciate the incidence of this disorder, you must be aware that thoracolumbar intervertebral disc protrusions and extrusions in dogs are very common. See Chapter 10. The majority of these protrusions and extrusions cause only discomfort. Many cause a mild to moderate degree of spastic paraparesis and ataxia in the pelvic limbs. Only a small percentage causes the clinical signs of a transverse spinal cord lesion that results in a spastic paraplegia and analgesia of the portion of the body and limbs caudal to the lesion. Of this latter group, about 5% to 10% will develop progressive diffuse myelomalacia, but no solution has been found to prevent its occurrence in these few dogs. It may occur in the face of the most appropriate and aggressive medical and surgical treatment for acute spinal cord injury. This disorder may occur even if decompressive surgery is performed prior to the development of any recognizable signs of progression of a myelomalacia. With a delay of 3 days to see whether progressive myelomalacia is going to occur, you will lose the critical time advantage in your surgical treatment of the much larger percentage of this group of spastic paraplegics that only have focal lesions. MRI may be useful in the early detection of the disorder in these patients. When the mixed signal on T2 weighted images begins to extend into the spinal cord segments adjacent to the initial site of injury from the intervertebral disc extrusion. Pelvic limb monoplegia. Dog signalment. 18-month-old castrated male shepherd mixed breed. Leo chief complaint. Unable to use the right pelvic limb history. Leo had been struck by a car 5 days prior to the video, and no change had occurred since that time. Examination. See video 5-46. Note that Leo walked well with 3 limbs, but the right pelvic limb was dragged along the floor, unable to protract or support weight. It was atonic and areflexic. Analgesia of the entire limb distal to the stifle in the caudal thigh and right side of the perineum and tail was present. Nociception was normal in the proximal medial thigh, genitofemoral, L3, L4, and in the cranial and craniolateral thigh, lateral cutaneous femoral, L3, L4. At the end of the video, the dog is facing away from the camera and I am straddling the dog and facing the camera. Tail tone was normal but it was held deviated to the left side. When I stimulated the normal left side of the tail, his nose suddenly came into view. This was followed by my palpation of the iliac crests to show the marked ventral displacement of the right ilium. I indicated a palpable deviation of the tail. Anatomic diagnosis. Right L4 through caudal spinal cord segments, Spinal nerve roots, spinal nerves, femoral and sciatic nerves, and sacral plexus. The asymmetry of the clinical signs strongly suggests that the lesion is in the nerves, not in the spinal cord, especially given the history of external trauma and the palpable displacement of the ilium. We have not seen a nerve root avulsion in the pelvic limb like we see in the thoracic limb without a fracture and bony displacement. The history of an observed external trauma eliminates any need to discuss a differential diagnosis. Radiography showed fractures of the right pubis and ischium and a right sacroiliac luxation with severe ventral and lateral displacement of the ilium. Figures 5-61 and 5-62. The latter was probably associated with a tearing of the termination of the iliopsoas muscle, which would account for the lack of hip flexion. It also would account for an injury to the femoral nerve, which emerges from the iliopsoas muscle to enter the quadriceps femoris. The sciatic nerve is commonly injured in pelvic trauma because it is formed by the L6 and L7 spinal nerve ventral branches that pass across the ventral surface of the sacroiliac joint, where they are at risk for injury by luxations. These two branches are joined by the ventral branch of S1 to form the sciatic nerve, which then courses across the dorsal surface of the body of the ilium where fractures are common. Surgeons must be aware of this nerve and not injure it when repairing fractures of the body of the ilium. The obturator nerve courses on the medial surface of the ilium and is at risk for injury by these iliac fractures, but the slight sliding out of the limb during weight bearing when the dog is walking on a slippery surface is probably not recognized. This would not be seen when the dog walked on a rugged or a grassy surface. The femoral nerve is rarely affected by these pelvic fractures because it is never directly associated with bones of the pelvis in its course from the psoas major muscle, where it is formed primarily by the ventral branches of the L4 and L5 spinal nerves and enters the quadriceps femoris. In Leo, the dog in this case example, the degree of iliac displacement ventrally from the sacrum was unusual and therefore injured the femoral nerve. The right sacral plexus may also have been torn by this marked displacement. A fracture of the first two caudal vertebrae caused the analgesia of the right side of the tail. The prognosis for recovery from such severe neurologic signs was poor, but the owners elected to have the sacroiliac luxation repaired. This repair was successful, but after 6 weeks, as the neurologic signs did not change, the limb was amputated. Leo was certainly given a chance for survival and was fortunate to have such dedicated owners. Video 5-47 shows Keen, a 1-year-old collie that had been struck by a car 1 week earlier and had suffered a fracture of the left pubis, ischium, and body of the ilium. Figure 5-63. The fracture and displacement of the ilium injured the sciatic and obturator nerves. Note how readily the limb is protracted by hip flexion and the ability to support weight, but the poids is often placed on its dorsal surface. The stifle flexors and the tarsal flexors and extensors are hypotonic. These signs indicate a sciatic and predominantly fibular nerve paresis. 150 nociception is intact when the lateral digit is compressed, which indicates that the sciatic nerve is still anatomically intact. Note that the left hind paw occasionally slides laterally on the slippery floor. This is caused by the obturator nerve injury. Figures 5-64 and 5-65 show a domestic short-hair cat with a similar pelvic fracture and injury. Video 5-48 shows Hershey, a 10-year-old male Gordon setter, which experienced 1 month of progressive gait abnormality in the right pelvic limb. Note the skipping tight gait, which is characteristic of his sciatic nerve dysfunction and is caused by the brisk, unopposed flexion of the hip. Weight support is normal, but during this support, the tarsus is overflexed, and the hind paw is occasionally placed on its dorsal surface. Remember the course of the nerves that form the sciatic nerve along the medial side of the ilium to cross the body at the greater ischiatic notch. On a rectal examination of Hershey, I palpated a mass. This was confirmed by radiography and MRI, which showed involvement of the ilium by the neoplasm. Figures 5-66 through 5-68. Microscopic examination of the mass led to the diagnosis of a sarcoma. Video 5-49 shows an adult parakeet with a right pelvic limb that could not be used to perch on its stand. This had been a slowly progressive problem that had progressed to complete inability to move the right pelvic limb. Note the normal brisk flexion of the left limb after being manually extended, and especially the flexion of the digits, sciatic nerve, which the bird needs to be able to perch. The right limb was analgesic and areflexic, and the muscles were atrophied. This was diagnosed as a sciatic and femoral nerve disorder. One recognized cause of this neuropathy in a parakeet is a compression of these nerves by a renal adenocarcinoma because they course adjacent to the dorsal surface of the kidney. The avian kidney is an elongated structure that is embedded on the ventral surface of the synsacrum, where these nerves are formed by the spinal nerves that emerge at this level. This diagnosis was confirmed at autopsy. Sciatic nerve injury. It is important to be keenly aware of the course of the sciatic nerve when you are performing intramuscular injections in the gluteal or caudal thigh muscles. If you are going to use the caudal thigh muscles for the injection, grasp the stifle from the caudal side with your hand, with your fingers wrapped around the cranial aspect of the extended stifle. Your thumb will fit into a depression between the biceps femoris laterally and semitendinosus medially. The sciatic nerve is directly cranial to your thumb at this level. Intramuscular injections in young animals should be placed in the epaxial muscle of the lumbar region or neck muscles to avoid this possible nerve injury. The sciatic nerve is also at risk of being injured when you are placing a needle into the trochanteric fossa to obtain a bone marrow sample. When you are placing an intramedullary pin through that same fossa for fracture repair, or placing cerclage wire around the femur when placing the stem of an artificial hip, or when you are performing a femoral head and neck osteotomy. LMN periparesis. Cow signalment. 4-year-old Holstein cow chief complained. Abnormal pelvic limb gait history. The owner noticed abnormal posture in the left pelvic limb 2 months prior to the examination. Over the next 2 to 3 weeks, the same abnormal posture occurred in the right pelvic limb, and the cow spent most of her time lying down. Examination. Video 5-50 shows her ability to advance her pelvic limbs and support weight, but with overflexion of each tarsus, drop tarsus, and with dorsal buckling of the metatarsalphalangeal. Fitlock, joints, nociception was normal on all surfaces of the digits. Metatarsus and crest tail and anal function were normal, and she was not incontinent. Anatomic diagnosis. S1, S2 spinal cord segments, spinal nerve roots, spinal nerves, sciatic or tibial nerves. This posture of the tarsus and digits is typical of a tibial nerve dysfunction in cattle. The overflexed tarsus is the result of loss of the innervation to the tarsal extensors, gastrocnemius, and superficial digital flexor muscles. The basis for the dorsal buckling of the metatarsalphalangeal joints is not clearly understood, but presumably represents the loss of the function of the digital flexors. It is a very reliable sign of tibial nerve dysfunction in cattle. This dorsal buckling of the metatarsalphalangeal joints does not occur with fibular nerve paralysis. A ruminant with fibular nerve paralysis stands on the dorsal aspect of the digits because of loss of the function of the digital extensor muscles, but the posture of the metatarsalphalangeal joints is normal. Differential diagnosis. Injury. Lymphoma, discus spondylitis injury. The most common injury in this area in adult cattle is fracture of the sacrum or the caudal vertebrae as the result of being mounted by a bull or another cow. Most of these injuries damage the caudal nerves to the tail and the sacral nerves to the anus and perineum, and the signs are immediate. If the injury affects the first 2 sacral nerves, a tibial nerve dysfunction will be observed. In this cow, the tail, anus, and perineum were normal, and the tibial nerve signs were progressive. Lymphoma is a common extradural tumor in adult cattle that are 4 or 5 years old or older. If lymphoma had been located in the cranial sacral vertebral canal, it could readily explain the progressive clinical signs observed in this cow. Discus spondylitis at the L6, S1 articulation, with abscess development in the cranial sacral vertebral canal, could also explain these progressive signs. Video 5-51 shows one of 2 2-year-old Holstein cows with this lesion, which was thought to be secondary to tail docking surgery performed a few weeks prior to the onset of clinical signs. In addition to the clinical signs of tibial nerve paresis, hypotonia and hypalgesia in the tail and anus, and hypalgesia in the perineum from involvement of the sacrocaudal segments, spinal nerve roots, or spinal nerves were observed. A rectal examination of the cow in this case example led to the diagnosis of a bony protrusion on the ventral aspect of the sacrum. It was thought to be a heel displaced fracture. This cow was euthanized and had autopsy. The bony mass was identified as a large callus associated with a heel displaced fracture of S2. Both the S1 and S2 spinal nerve ventral branches were enclosed in fibrous tissue bilaterally, causing a compressive neuropathy and explaining the progressive bilateral tibial nerve paresis in this cow. Be aware that a common cause of unilateral sciatic nerve paralysis in calves is iatrogenic in origin, resulting from the intramuscular injection of drugs into the gluteal or caudal thigh muscles. Figure 5-69. These muscles are poorly developed at that age, making the sciatic nerve more easily accessed by these injections than they are in older animals. However, the gluteal muscles of adult dairy cattle are also thin and should not be used for intramuscular injections. These affected animals may not recover if the drug that is injected causes disruption of the neuronal axons. To avoid such injury, place intramuscular injections into the neck muscles. When an intrasciatic injection happens in a pen of young pigs, the denervated analgesic digits may be mutilated by the carnivorous activity of the penwit pigs. Figures 5-69 and 5-70 show a 2-month-old calf and a 5-year-old cow and demonstrate the results of injury to portions of the sciatic nerve by intramuscular injection of drugs into the pelvic limb. Be aware and take special note that if a cow is bitten in the pelvic limb by a rabid fox or another rabid animal. The first signs of rabies virus encephalomyelitis may reflect the involvement of gray matter in the lumbosacral intumescence. The clinical signs change rapidly because this disease progresses very fast and usually causes recumbency in a few days and death in 7 to 10 days. LMN paraparesis, dog signalment, 4-year-old castrated male Leonberger. LMN paraparesis, dog signalment, 4-year-old castrated male Leonberger, Bo chief complaint, abnormal pelvic limb gait history. The abnormal gait in both pelvic limbs had been slowly progressing for 4 to 6 weeks. At 3 years of age, idiopathic laryngeal paralysis was diagnosed as the cause of an inspiratory dyspnea, and tie-back surgery was performed on the larynx. Examination. Video 5-52 shows the skipping type gait in the pelvic limbs, which is related to the brisk overflexion of the hips. This has sometimes been confused with a cerebellar hypermetria. It represents the loss of tone in the antagonistic caudal thigh hip extensor muscles that are innervated by the sciatic nerve. Note the mild overflexion of the tarsus and the occasional placement of the hind paw on its dorsal surface during the hopping test. The flexor response to a noxious stimulus of the digits occurred mostly at the hip and was depressed at the stifle and tarsus. Nociception was intact throughout both pelvic limbs. The tarsus was hypotonic bilaterally, and crural muscle atrophy was extensive. Anatomic diagnosis: bilateral L6, L7, S1 spinal cord segments, spinal nerve roots, spinal nerves, sciatic nerves, bilateral recurrent laryngeal nerves. Differential diagnosis: inherited distal polyneuropathy, metabolic neuropathy, neoplasm Leonberger. Inherited neuropathy and inherited distal polyneuropathy is the most presumptive diagnosis in both, based on the breed, the bilateral signs, and the history of previous laryngeal paralysis. This has been described as a dying back neuropathy affecting the distal portions of long neuronal axons. The onset of clinical signs varies from 1 to 3 years. The recurrent laryngeal nerves and the sciatic nerves contain the longest peripheral axons in domestic animals, and their degeneration is responsible for the clinical signs seen in this disorder. Electrodiagnostic studies show abnormalities in all the distal appendicular muscles. This is an autosomal recessive inherited disorder that is more common in males. This canine disorder has been compared with Charcot-Marie tooth polyneuropathy in humans. The Leonberger breed was derived from the crossing of the Newfoundland, St. Bernard, and Great Pyrenees breeds. Prior to repair of the paralyzed larynx, owners should be warned of the likely progression of this disorder in the Leonberger. Indeed, in any young patient that develops laryngeal paralysis, concerns for progression involving other long nerves should be discussed. Metabolic neuropathy, diabetes, and hypothyroidism are metabolic disorders that may cause a neuropathy in dogs and cats. Tibial nerve paresis is the most common diabetes-related neuropathy and is most common in cats. The resultant tarsal overflexion causes a plantigrade posture that is quite remarkable in these cats. It often resolves when the diabetes is well controlled. Video 5-53 shows an 11-year-old domestic short-hair snowball with diabetic neuropathy. We have also seen diffuse neuromuscular paresis associated with diabetes in cats and resulting in tetraparesis. Hypothyroid neuropathy is thought to result from the decrease in adenosine triphosphatase, ADPase, activity that is needed for axonal transport. The clinical expression is variable. It may affect the tibial nerves, the recurrent laryngeal nerves, the facial or vestibular nerves, and possibly the vagal nerves to the esophagus. Only a very small portion of dogs with chronic hypothyroidism develops a neuropathy and exhibits clinical signs. Old dogs commonly have a moderate degree of atrophy of the muscles of mastication and of the lateral scapular muscles. Such atrophy may have a metabolic basis. Inherited neuromyopathy, dancing Doberman. Video 5-54 shows a 6-year-old spayed female Doberman Pinscher that has exhibited a progressive pelvic limb gait abnormality for about 1 year. Note the flexed posture of the tarsus and the severe atrophy of the caudal crural muscles, suggesting a chronic tibial nerve disorder. Note the frequent elevation of each limb as the dog shifts its weight from one pelvic limb to the other and often sits down. Dogs in this situation act as if they are in some discomfort, but palpation does not cause discomfort. This shifting type of lameness has led to this disorder being called dancing Doberman disease. 17. Some discrepancy exists in the understanding of the underlying lesions responsible for this disorder. Some dogs have severe chronic neuropathy and denervation atrophy. Others have no neuropathy but severe primary myopathy of the caudal crural muscles. Until this dilemma is resolved, we consider this to be a neuromyopathy that is presumably inherited in the Doberman Pinscher. The onset of clinical signs may occur anytime between ages 6 months and 7 years and progress slowly, but they remain in the distribution of the tibial nerve and the muscles that it innervates. I monitored one dog with this syndrome for 8 years, and the clinical signs slowly progressed, but the dog retained its ability to walk until it was euthanized for unrelated issues. Inherited hypertrophic neuropathy. 2 other inherited disorders that involve the PNS are rare but worth mentioning. One is an autosomal recessive inherited hypertrophic neuropathy that occurs in Tibetan Mastiffs. A small number of this breed exist in the United States. Clinical signs usually begin between ages 7 and 12 weeks and progress rapidly. Paresis starts in the pelvic limbs with a symmetrically decreased ability to support weight, the development of plantigrade posture, hypotonia, loss of the patellar reflexes, and decreased flexor reflexes but intact nociception. Figure 5-71. In most dogs, the clinical signs progress to the thoracic limbs in a few days, with decreasing ability to support weight. Severely affected dogs become recumbent within about 3 weeks but retain voluntary limb movements. Non-ambulatory tetraparesis. Limb contractures may occur in the recumbent dogs. A few recumbent dogs improve after 6 to 7 weeks and regain the ability to stand and to walk with a shuffling plantigrade gait. Muscle atrophy is mild. On EMG studies, rare denervation potentials are observed, but nerve conduction rates are markedly prolonged, suggesting a myelin disorder. This is supported by the light and electron microscopic studies of nerves that show a widespread primary demyelination with Schwann-Sau hyperplasia and onion bulb formation with minimal axonal degeneration. The Schwann-Sau hyperplasia and onion bulb formation are the basis for the gross finding of nerve hypertrophy. This inherited defect appears to involve the Schwann cells and their ability to form and maintain stable myelin sheaths. The role of the axon signaling in this process is unknown. This inherited disorder first occurred in a kennel in which 15 affected puppies were diagnosed with this neuropathy out of a total of 62 puppies from 10 litters. Inherited giant axonal neuropathy. The second inherited disorder is an autosomal recessive inherited giant axonal neuropathy that occurs in the German Shepherd dog breed. 53 clinical signs begin around 15 months of age with a symmetric paraparesis and ataxia of the pelvic limbs that slowly progresses. After many months, these dogs become unable to stand with the pelvic limbs and exhibit patellar reflex loss, distal muscle atrophy, and hypalgesia in the pelvic limbs. By 16 to 20 months, the bark may be reduced, and fecal incontinence and regurgitation may occur. EMG studies early in the course of the disorder show decreased amplitude of evoked muscle and sensory neuronic potentials. Denervation potentials occur later in the disease process. Lesions of focal axonal swelling, spheroids, that contain dense whorls of 10 nanometer, nm, neurofilaments occur in the distal portions of the longest nerves as well as in the distal portions of long neurons in the CNS. The clinical signs are thought to represent primarily the nerve lesion. This axonal disorder may involve an inherited metabolic defect that causes a disorder of the 10 nm neurofilaments and results in impaired axonal transport. LMN paraparesis. Horse signalment. 12-year-old quarter horse gelding. Tommy Chief complained. About 3 weeks before examination, this horse suddenly displayed severe lameness in the left pelvic limb. No injury was found, but the lameness got worse despite changing the shoes and providing a chiropractic adjustment. Examination. An extensive orthopedic examination, including nerve blocks and local anesthesia of joints, did not diagnose any abnormality. Video 5-55 shows the examination. Note the severe weight bearing lameness with no indication of any reluctance to use the limb. This lameness in the absence of any recognizable discomfort in the presence of a normal orthopedic examination must be considered an inability to support weight. Note that the right pelvic limb is also mildly paretic, as indicated by how easy it is to push the horse to its right side. Note the normal response to a noxious stimulus on the medial side of the left cross. Anatomic diagnosis. L4, L5 spinal cord segments, spinal nerve roots, spinal nerves, and femoral nerves, worse on the left side. For weight support in the pelvic limb, the femoral nerve and the quadriceps femoris muscle must be intact, because of the reciprocal apparatus in the horse. When the stifle flexes on collapsing, the tarsus also flexes, which exacerbates the limb collapse. Some femoral nerve neurons are still functional, according to the normal nociception observed when the medial surface of the left cross was pinched with forceps. This cutaneous area is in the autonomous zone of the saphenous nerve, which is the cutaneous branch of the femoral nerve. Differential diagnosis. Equine protosomal myelitis, lymphoma, other neoplasm, neuritis. Equine protosomal myelitis is the most presumptive clinical diagnosis, based on the progression of signs, the asymmetry of the signs, the gray matter involvement, and the common occurrence of this disease in adult horses. The clinical onset may vary from being remarkably acute and rapidly progressive to having a slow onset and chronic progression. This disease is described in Chapter 11, see case example 11-2. Lymphoma is an uncommon disease of the nervous system of horses. However, infiltration of the L4 and L5 spinal nerve roots, spinal nerves, or femoral nerve could cause these signs, but the lesion would have to be bilateral. Other neoplasms are quite rare in the spinal cord or nerves of horses. The only recognized neuritis in the horse is polyneuritis equi, neuritis of the cauda equina, and the anatomic diagnosis of Tommy would be very unusual for this disorder. Be aware that the first clinical signs of rabies virus encephalomyelitis may involve gray matter of the lumbosacral intumescence and cause LMN signs in the pelvic limbs if bitten in the pelvic limbs. This will change rapidly because the disease progresses fast, and most horses will be down in 4 days and dead by 7 to 10 days. West Nile virus also causes a poliomyelitis, and the early signs of this disease may reflect this gray matter lesion. Lumbar CSF obtained from Tommy contained a slight elevation of mononuclear cells, 9 white blood cells per mm3, 2 red blood cells per mm3, and 43 mg protein DL. Serum was positive for antibodies against S. neurona. Tommy was treated with antiprotozoal drugs for 2 weeks, but clinical signs in the right pelvic limb continued to progress. The horse was euthanized, and the autopsy diagnosed an extensive non-suppurative myelitis, primarily within the caudal lumbar spinal cord segments. The lesion was typical of that caused by S. neurona, but no organisms were found in the lesion. This is typical in a horse that has received treatment for this organism. LMN paraparesis, calf signalment. 3-day-old Holstein calf Chief complained. Lameness in the left pelvic limb. History. Since its birth, this calf has exhibited pelvic limb lameness. The birth was difficult and required manual assistance. The calf's head and thoracic limbs presented, but to free the calf's pelvic region from the cow's pelvic canal required the extraction efforts of 2 people. Initially, the calf needed help to stand, and the lameness had not changed since birth. Examination. Video 5-56 shows the marked inability to support weight with the left pelvic limb but no reluctance to try. A similar but much milder lameness was present in the right pelvic limb. No paddle law reflex was present in the left pelvic limb. Nociception was normal on all surfaces of both pelvic limbs. Anatomic diagnosis. L4, L5 spinal cord segments, spinal nerve roots, spinal nerves, or femoral nerves. Differential diagnosis. Injury, malformation, myelitis dystocia injury, femoral nerve. The presence of these clinical signs at birth, with no change over the period of 3 days, strongly supports an injury to the femoral nerves that is worse on the left side. It is well recognized that the femoral nerves are at risk for being injured when a dystocia due to a hip lock leads to vigorous overextension of the hips when the extraction of the calf requires manual assistance. This overextension puts traction on the femoral nerve or its roots. Most publications describe hemorrhages or disruption of the femoral nerve where it emerges from the iliopsoas muscle to enter the quadriceps femoris. If the injury is mild, spontaneous recovery may occur in a 2 to 4 week period, as it did in this calf. Malformation of the spinal cord must be considered when the signs are present at birth and are non-progressive. However, we have never seen a myelodysplasia cause a neurologic deficit that is asymmetric and is limited to the femoral nerves. Recall that most calves with myelodysplasia that are ambulatory will show a bunny hopping simultaneous protraction of the pelvic limbs. The only myelitis present at birth that would concern us in calves would be that caused by an in utero infection by incaninum, which is a common cause of abortion in cattle. 50 occasionally, calves that are infected late in gestation are born with signs of spinal cord dysfunction caused by the myelitis portion of a diffuse encephalomyelitis. It would be very unusual for these signs to involve only gray matter of the L4 and L5 spinal cord segments. Video 5-57 shows a 1-week-old female Holstein calf that required significant assistance for its birth. Since birth, she had walked lame on her left pelvic limb. The initial diagnosis was a congenital patellar luxation. Note the lack of discomfort in using the limb, the inability to support weight, the atonic cranial thigh muscles, the laxity of the patella, the lack of a patellar reflex, and the analgesia of the medial aspect of the left cross. Compare the response of the calf to a noxious stimulus to the medial cross of the left pelvic limb with response to the same area of the right pelvic limb in the plantar aspect of the left metatarsus. Your anatomic diagnosis should be complete dysfunction of the left femoral nerve. What does this tell you about which pelvic limb nerve the calf needs to kick you? The analgesia in the distribution of the saphenous nerve branch of the left femoral nerve makes the prognosis for spontaneous recovery guarded. The owners raised this calf and had a follow-up at 18 months of age. Her gait remained unchanged. Video 5-58 shows a 3-month-old Hereford calf with a similar history of a dystocia that required manual assistance and a diagnosis of right femoral nerve paralysis since birth that had not changed. This calf was euthanized, and an autopsy revealed an avulsion of the L4 and L5 spinal nerve roots on the right side. This is the only spinal nerve root avulsion we have seen involving the pelvic limbs that was not associated with a fracture. Small animals that are struck by motor vehicles and suffer sacrocaudal fracture with significant displacement are at risk for avulsion of the sacrocaudal nerves. Femoral nerve injury may also occur in adult cattle that are recumbent because of a metabolic disorder such as hypocalcemia. This occurs when a cow is on a concrete surface and struggles to stand up. If the pelvic limbs slide out caudally, the femoral nerves may be stretched and torn, and the quadriceps femoris muscle may be injured. This may be avoided by keeping the cattle in stalls that have sand surfaces when they calve or have an illness that may cause recumbency resulting from paresis. A cow is also at risk for a nerve injury during a dystocia. The obturator nerve may be compressed where it lies on the medial surface of the body of the ilium. The loss of the adductor muscles that this nerve innervates will not be seen if the cow freshens at pasture or in a box stall with a dirt floor. If she is on a concrete surface, she will severely abduct the limb when it tries to stand up, and this may tear the adductor muscles on the medial side of the thigh. Similarly, dystocia may cause compression of the ventral branch of the L6 spinal nerve, which lies against the prominent ventral surface of the cranial aspect of the sacrum as it courses caudally to join the ventral branches of S1 and S2 spinal nerves to form the sciatic nerve. Most of these L6 nerve fibers are destined to form the fibular nerve. Their compression causes the cat to have difficulty extending her digits, and she will stand on their dorsal surfaces. The same clinical signs of fibular nerve paralysis may occur in a cow that is recumbent in a stanchion and her recumbent pelvic limb lies across the edge of the gutter. Pressure may be placed on this nerve where it is subcutaneous as it crosses the lateral head of the gastrocnemius muscle to enter the craniocrural muscles. LMN paraparesis, dog signalment, 9-year-old castrated male Doberman Pinscher, Zappa chief complaint, unable to stand using the pelvic limbs history. Just 6 days prior to our examination, the owner noticed that Zappa was having difficulty with his pelvic limbs when he went up or downstairs, and he tripped when crossing thresholds. He was treated with corticosteroids and a muscle relaxant. The owner thought he was better the next day, but the following day, he was worse and became unable to get up using his pelvic limbs. Examination. Video 5-59 shows that this dog cannot stand by himself when assisted. Note how he exerts himself to try to stand and walk and how fast he moves his pelvic limbs. He takes very rapid short strides, always in a crouched position because he cannot support his weight. Hip flexion is normal for protraction but stifle extension is inadequate. A mild decrease in tone distal to the hips was observed, especially in the left pelvic limb, and the left patellar reflex was more depressed than the right. Flexor reflexes and nociception were normal. Anal tone was normal, but the tail was too short to evaluate well. During the examination, constant dribbling of a small amount of urine was seen. Occasionally, Zappa presented firm palpation of his lumbar vertebrae. Anatomic diagnosis: bilateral L4, L5 spinal cord segments, spinal nerve roots, spinal nerves, and femoral nerves. Slight involvement of the same sacral components. This anatomic diagnosis is uncommon. More often dogs with spinal cord disease cannot stand because of a UMN dysfunction. If some UMN is still intact and the dog is assisted to stand, a delay will occur in protraction of the limbs and the movements will be slow. This is in contrast to the rapid protraction efforts made by Zappa, where the dysfunction was primarily caused by the lack of sufficient support because of loss of femoral nerve activity. Differential diagnosis: intervertebral disc extrusion, FCEM, neoplasm intervertebral disc extrusion and acute intervertebral disc extrusion was the most presumptive diagnosis in Zappa, based on the rapid onset of clinical signs, the brief improvement followed by rapid progression of clinical signs, and the suggestion of some discomfort on palpation of his lumbar vertebrae. FCEM is a strong possibility, but the history of a brief improvement and then progression of clinical signs would be unusual in that disorder. The occasional discomfort is more common with intervertebral disc extrusions but may initially occur with FCEM. Extraparenchymal neoplasms may slowly compress the spinal cord without causing clinical signs until the vascular autoregulation is suddenly overwhelmed and clinical signs occur rapidly. Thus, neoplasm must be a consideration here. The video shows images from radiography, the myelogram, and CT myelogram that were performed on Zappa. They showed a large accumulation of intervertebral disc material over the body of L5. The CT section started at the cranial aspect of L4 and continued to the caudal aspect of L5. Zappa was euthanized, and this diagnosis was confirmed at autopsy. In general, patients with intervertebral disc extrusion have an excellent prognosis with surgical intervention. This is especially true in those dogs that are still able to walk to some degree at the time of presentation. Pelvic limb dysfunction, dog signalment, 6-year-old male German Shepherd dog, Jerry chief complaint, right pelvic limb lameness history. For the past 2 months this dog had an abnormal gait in the right pelvic limb. After 3 to 4 weeks of progression, the signs had been static. It did not interfere with the level of activity. Examination. Video 5-60 shows that Jerry exhibited no discomfort when chasing the dummy. No impairment occurred in the dog's ability to advance the right pelvic limb and support weight, and the positions of the tarsus and digits were normal. Note that at the end of protraction, swing phase, the right hind paw was suddenly slightly elevated and quickly placed on the ground. At the same time, a slight medial deviation of the stifle and lateral deviation of the tarsus occurred. Fibrosis. Quadromedial thigh muscles. No neurologic disorder causes this abnormality. It is the result of the development of a fibrous band associated with the muscles on the quadromedial aspect of the thigh that arise from the pelvis and terminate on the proximal medial surface of the tibia. These are the semitendinosus, semimembranosus, and gracilis muscles. Most commonly this fibrous band is associated with the semitendinosus muscle. Full extension of the protracting limb depends on smooth relaxation of these antagonistic muscles. The fibrous band prevents this and mechanically terminates the protraction prematurely, resulting in the brief elevation of the pons and sudden return to the ground. At the same time, the medial termination of this top band on the proximal tibia forces a medial rotation of the stifle. When the stifle rotates medially, the tarsus always rotates laterally. In most dogs, this fibrous band may be palpated on the quadromedial aspect of the thigh. In the literature, this has been referred to as fibrotic myopathy of the quadromedial thigh muscles. 92. It is most common in the German Shepherd dog breed. It has been proposed that an injury that tears a muscle in this group will result in fibrosis associated with the healing of the tear, and this will shorten the length of that muscle and result in the clinical signs seen here. This is a concept similar to that of the infraspinatus fibrosis that occurs in the thoracic limb. I have studied 3 surgical specimens of semitendinosus muscles with this fibrous band that were removed from Jerry in dogs similar to Jerry. In all of them, a dense fibrous band was present on one surface of the muscle, but the adjacent muscle was normal. No indication of any myopathy existed, and no fibrosis was associated with the healing of an injured portion of muscle. The band consisted of well-organized bundles of collagen. Figure 5-72. The cause of this fibrous band is unknown, but it must be removed to return the gait to normal. However, recurrence of this fibrous band is likely, and therefore surgery should be considered with caution. No indication that this fibrous band causes a dog any discomfort was observed. These dogs readily run, jump, and play with vigor, like Jerry in this video. Occasionally, this disorder occurs bilaterally. I have now examined or observed videos of numerous working police dogs, mostly German Shepherd dogs, and in all cases, trainers report that the dog's performance is not impeded by this disorder. Video 5-61 shows another example of this muscle disorder in a 7-year-old male German Shepherd dog with his trainer. This was a working police dog. Video 5-62 shows a 17-year-old female standard bred. At 7 years of age, she fell and fractured her pelvis and left greater trochanter. She had been Video 5-62 shows a 17-year-old female standard bred. At 7 years of age, she fell and fractured her pelvis and left greater trochanter. She had been used as a brood mare since then. It is not known when her lameness first developed, but it had been present for a number of years. Note the same abrupt termination of the protraction phase of the gait in the left pelvic limb, as was seen in Jerry, but no medial rotation of the stifle has occurred. Note the top band that is palpated on the quadromedial side of the left thigh. This mare was euthanized, and had autopsy. Extensive fibrosis of the proximal medial thigh muscles was observed, as well as considerable neuropathy in the branches of the sciatic nerve to these thigh muscles, all resulting from the injury. This gait disorder has been reported in horses that injure these muscles when they rest their caudal thighs on the chains that hold them in trailers for transportation, or when these muscles are injured by repeated intramuscular injections of large quantities of drugs. Injury to the intramuscular branches of the sciatic nerve may play a role in the chronic shortening of these muscles in the horse. Plantigrade posture, whereas a significant palmigrade posture is the result only of loss of the integrity of the palmar-carpal ligaments. A plantigrade posture has at least 4 different anatomic causes. 1. A tibial nerve dysfunction with innervation of the tarsal extensor muscles, the gastrocnemius and the superficial digital flexor. 2. A rupture of part or all of the common calcanean tendon. 3. A fracture of the calcaneus. 4. A disruption of the long plantar ligament. Video 5-63 shows Chet, an 11-year-old castrated male domestic shorthair, with a bilateral rupture of the gastrocnemius tendon, but the superficial digital flexor tendon has been spared. He is reluctant to move out of the discomfort of the lesion. Note that when the tarsus overflexes, the digits flex because of the stress put on the intact superficial digital flexor tendon that attaches to the calcaneus. Ultrasonographic examination showed changes suggestive of degeneration within the ruptured gastrocnemius tendon. In figures 5-73 through 5-75, note the same posture of an Obermann pincher with a similar gastrocnemius tendon rupture at the level of the left pelvic limb calcaneus, with sparing of the superficial digital flexor. The cause of these tendon ruptures was unknown. Equine pelvic limb disorder signalment. 16-year-old female, Appaloosa history, donated to the teaching hospital because of an abnormal gait that had been present for several weeks. Examination. C. Video 5-65. String halt. This abnormal gait is referred to as string halt and represents the hyperactivity of flexors of hips, stifle, tarsus, and digitated by the reciprocal apparatus. It involves a disorder of the central pattern generators of spinal cord segments L4 through S2, their roots, spinal nerves, spinal ganglia, femoral, sciatic, fibular, and tibial nerves. The disorder may date back to the times of Shakespeare's Henry VIII, the spavin or spring halt among them. Two forms are recognized. 1. The sporadic, or classic, form affects individual horses with a sudden onset, unilateral or bilateral with no associated CNS or PNS lesions. Treatment consists of surgical removal of the tendon of insertion of the lateral digital extensor muscle or oral phenytoin. Neither of these therapies is effective in all patients. 2. Epidemic, or plinth associated, form occurs in pasture-bred horses where false dandelion, flatweed, cat's ear, Hippoteuris radicata, is present. This is especially common in Australia but also occurs in other countries including areas in the United States. A number of weeks of grazing is required before bilateral string halt suddenly occurs. A prolonged recovery will follow immediate removal of the affected horses from the pasture. This form of string halt is related to a dying back axonopathy of branches of the sciatic nerves in the pelvic limbs. Neurogenic atrophy occurs in crural muscles. Video 5-66 is an example of the epidemic form of string halt in a 17-year-old castrated male mixed breed horse that developed an abnormal gait in the pelvic limbs after 3 to 4 weeks on a pasture that contained false dandelion plants. Other horses on the pasture were similarly affected. Stiffness in a kid signalment. 1-month-old female mixed breed kid goat. GIMP chief complaint. Inability to stand history. The day before examination, this kid could not stand up without assistance. No obvious change had occurred during the short period before the examination. This goat farm had a history of listeriosis in kids, which appeared to be related to the time when they were losing their deciduous teeth. GIMP was taken to Cornell for an autopsy to confirm the diagnosis of listeriosis, but a clinical examination was requested by the pathologist prior to euthanasia. Examination. Video 5-67 shows severe hypertonia, especially in the pelvic limbs, related to any stimulation. Note the absence of any obvious ataxia and the normal postural reactions by the thoracic limbs as well as attempts to overcome the hypertonia and perform the actions using the pelvic limbs. The hypertonia was too severe to permit the testing of the spinal nerve reflexes in the pelvic limbs. The muscles were prominent and firm on palpation. Anatomic diagnosis. Diffuse muscle disorder or diffuse spinal cord ventral gray column loss of inhibition differential diagnosis. Vitamin E deficiency myopathy. Inherited myotonia. Myositis. Dystrophinopathic. Duchenne. Muscular dystrophy. Tetanus. Vitamin E deficiency myopathy. The most common muscle disorder in young ruminants and foals is the myopathy rhabdomyolysis associated with vitamin E and selenium deficiency. This is known as stiff limb disease in sheep, and certainly the primary clinical sign in this goat was stiffness. The most likely cause is myotonia or pseudomyotonia as a result of disturbance of the muscle cell membranes. We are not aware of any EMG studies in these cases that would support or deny this hypothesis. In contrast, inherited myotonia is an episodic disorder in goats, evidenced by short periods of stiffness between long periods of normal muscle function. See videos 20-1 and 20-2 in chapter 20. Protosomal myositis caused by infection by T. gondii is uncommon, especially when accompanied by such diffuse severe hypertonia. A dystrophinopathic type of muscular dystrophy has not been reported in farm animals or horses. A moderate form of tetanus has to be considered in this kid. Only the lack of head muscle involvement makes it less likely. Severe muscle necrosis was confirmed by the remarkable elevation of serum muscle enzymes. CK was international units. IU, normal is less than 446 IU. AST was 1393 IU, normal is less than 158 IU. On the basis of this information, the presumptive diagnosis was vitamin E deficiency myopathy. Necropsy was cancelled, and GIMP was treated with vitamin E and selenium and given a guarded prognosis because of the severity of her clinical signs. She was adopted and lost to follow-up evaluation. Signalment. 11-year-old castrated male domestic short-hair cat. Bandit chief complaint. Head tilted, not walking right history. This indoor-only cat was normal until 1 month ago. Around that time, the owner accidentally stepped on the cat and over the subsequent 24 to 48 hours noticed an abnormal gait. Such an accident had never occurred before. The cat was brought to the referring veterinarian, who diagnosed head tilt and placed the animal on corticosteroid and antibiotic therapy for presumptive otitis. The signs progressively worsened. The owner and the referring veterinarian noticed that the cat's head was held low to the ground and that he would put his head flat on the ground whenever he stopped moving. The cat walked around the house with this abnormal flexed position of the head, but no change was noticed in her vocalization. Examination. Video 5-68 is a series of videos showing the cat's abnormal flexion of the neck and the head held closer to the ground while walking. The scapulae are positioned in a more dorsal position, protruding above the horizontal plane of the epaxial muscles. The thoracic limbs are thrown forward without an apparent ataxia. The cat was able to jump onto a chair. Not shown on the video, whenever the cat stopped walking, he would lay his head down on the ground. Evaluation of the spinal reflexes, tone of the limbs, and muscle size were all normal. The cat did not exhibit pain or manipulation of the neck, limbs, or any specific muscles. Anatomic diagnosis. Neuromuscular disease to account for abnormal flexion of the neck and the protruding scapulae along with the limbs being thrown forward on protraction. Differential diagnosis. For flexion of the neck in a cat, the list of differential diagnoses should include hypokalemia, thiamine deficiency, hyperthyroidism, myasthenia gravis, diabetes mellitus, polymyositis, and organophosphate toxicity. We have occasionally seen that cervical myelopathy from infarctions or neoplasms cause weakness of the neck muscles in cats and the resultant flexion of the neck, but these diseases in the cervical spinal cord usually also result in a general, proprioceptive ataxia and oculomotor neuron paresis in all 4 limbs. Ancillary studies. A minimal database was collected on Bandit and included complete blood cell count, CBC, chemistry panel, including creatine kinase, CK, levels, and thyroxine level. Additional tests included radiography of the thorax, abdomen, and cervical vertebral column, serum titers for acetylcholine receptor antibodies for the diagnosis of myasthenia gravis, and serology for infectious diseases, including feline leukemia virus, FeLV, feline immunodeficiency virus, FIV, Cryptococcus neoformans, and T-gon-DI, CBC, thyroxine level, acetylcholine receptor antibody test, and titers for the infectious disorders were all normal, as was radiography. The chemistry panel revealed a serum potassium concentration of 2.9 mg/dl, with normal serum potassium being 3.5 to 5.8 mg/dl. The CK was also elevated at 3,900 IUL, with normal being up to 314 IUL. Abdominal ultrasonography was then performed, and it revealed a right adrenal mass. Serum aldosterone levels were elevated, confirming the diagnosis of an aldosterone-secreting neoplasm of the adrenal gland. CK may be elevated in hypokalemic patients. Usually, with primary myositis, the CK level is much higher. Bandit received intravenous fluids with supplemental potassium. Once his serum potassium concentration increased, his head and neck posture, positioning of his scapulae, and thoracic limb gait returned to normal. The right adrenal tumor was removed. Hypokalemia has also been reported as a cause of a primary myopathy in the Burmese breed of cat and is referred to as feline hypokalemic periodic polymyopathy. In this breed, hypokalemia is associated with a defect identified in a locus on chromosome E1 and in the gene WNK4, and a genetic test to screen for the genetic defect has been developed. These Burmese cats have a characteristic stance and gait, similar to Bandit in this case example, with a flexed neck and protruded scapulae. Humans with neuromuscular disease may also develop the flexion of the neck, and this is referred to as drop head syndrome.